a young girl, perfectly well 1 year ago, developed fear of stairs and also had change of behavior, emotional lability, restlessness, and also violent behavior, shown to a psychiatrist and started on treatment. So looks like a case of psychiatric illness, isn't it? And also mother noticed that she gets up several times at night to pass urine, became very thin and dry, admitted to hospital and to initially to a base hospital and then to a national hospital. Anybody wants to give any guesses at this point? Any volunteers? Don't take too much time. Just shout. This is very informal because, you know, I'm not marking you for your final MBBS. Can't you hear, guys?
Yes, sir.
Sorry?
Patient
Sorry?
may be having hypoglycemia and
Hyperglycemia. So actually, you know, I think you might have to change this attitude of, you know, being very, this is not very good for Sri Lankan undergraduates. You all behave like, you know, I'm sad to say that a very dumb group of people. And when we have to change from this attitude, and, you know, if you do this sort of a thing in other country, this is much different, right? You know, adult learning is, it's active learning, interactive, just not trying to copy everything and this thing. Try to, because if you have to feel free to, because even I asked this question from a ordinary group of people, they will say that the patient might have diabetes. So try to be more interactive and active in participation. So this patient was diagnosed as type 1 diabetes and also hypertension at the same time. Discharged on insulin and follow up at a base hospital. Is this like, you know, anything unusual here in this girl? Anyone?
Developing hypertension at this stage because she's young.
What is unusual?
She's her age, she's 20 years old.
So if this is older woman, older person, type 2 diabetes would have been much commoner, isn't it? So having diagnosed with type 1 diabetes tension is bit unusual. So you need to now start thinking whether am I dealing with something atypical. Okay. So this is not very usual. So you need to think laterally and need to ask further questions. Now, if I take you to these ones, right? Can you guys think of anything more as possibilities to this case?
Diabetes insipidus.
Was hyperglycemia. So because this patient, you know, diagnosed as type 1 means definitely the patient would have had high glucose, isn't it? So diabetes insipidus also is not a condition that by itself causes hypertension. So, can anyone of you think of a cause that causes diabetes, hypertension, change of behavior?
Thyroid problem, hyperthyroidism.
Yeah, hyperthyroidism can to some extent, but hyperthyroidism does not cause severe hyperglycemia. It can cause very mild hypertension and systolic hypertension and hyperglycemia. So any other condition that would lead to more aggressive hyperglycemia and hypertension?
Cushing-like syndrome.
Yeah, and also fits in with the psychiatric illness, isn't it? So Cushing's becomes quite high up in this case. So the patient in addition has amenorrhea, loss of scalp hair, difficulty in getting up of seated position. What does that mean?
Proximal myopathy.
Yeah, proximal muscle weakness. So problems identified are psychiatric illness, rapid onset severe diabetes, hypertension, proximal muscle weakness. So what are the differential diagnoses here? So everything can be attributed to Cushing's, but rather aggressive Cushing's, and also rarely there can be more than one possibility, but that is usually not very common, right? So Cushing syndrome comes quite high up in the cards. Isolated diabetes, hypertension, psychiatric illness, all these things in a young person is quite rather uncommon. Pheochromocytoma can cause hypertension, but does not cause proximal muscle weakness. Can cause fear and some apprehension, anxiety, and mild hyperglycemia, again not severe hyperglycemia. And there are rare endocrinopathies with renal disease. So these are the possibilities, but Cushing's seems quite high up, isn't it? And then examination, right? Now, what can you see?
Hirsutism.
Hirsutism. And laterally, what can you see here?
Buffalo.
Buffalo hump, right? Suprascapular fat pad. Now, when you look here, what are the things that's more prominent, like, overall?
Central obesity.
Central obesity and peripheral sort of, thinning, right? And also, if you look at the face compared to the limbs, like there's some degree of, like, some degree of moon face sort of thing, right? The abdomen, there is no typical striae, but these are actually fungal infections. So the patient's blood pressure was high, severe proximal muscle weakness, and so the differential diagnosis comes now. Cushing seems quite, high up, but other things are very much rarer now. But if you want to give some DD, severe diabetes with PCOS, severe diabetes, hypertension with psychiatric illness, other possibilities. The blood glucose is like this. What are the abnormalities?
Urine ketone bodies.
Anyone? Yeah, urine ketones positive, but blood pH, what does that show?
So alkalosis.
Alkalosis, yeah. So does it fit in with type 1 diabetes and DKA?
Yes.
So in DKA, the pH has to be low. So in people with dehydration, starvation, breakdown, of fat, they can have urine ketones without acidosis, right? So, and the other marked abnormalities are high sodium and low potassium, right? Very low potassium, very, very low. So patient can die if you don't do something sooner. So all these other things, WBC is high, right? So that might point to an infection, as well as you might need to think other causes of high WBC without infection. Any conditions that you guys know of high WBC without infection? Anyone?
Lymphomas.
Yeah, any bone marrow disorders where the production leukemias, lymphomas, more for leukemias rather than lymphoma, isn't it? And then trauma, initial trauma, inflammation, and steroid use is very common cause of high WBC. Steroids increase WBC. So these are, again, now we are further trying to narrow down our DD, right? So high steroid, glucocorticoid levels can explain all these things, isn't it? Right? When you have very high glucocorticoids, they also have their mineralocorticoid effects, which will cause severe potassium loss with sodium, absorption, and sodium absorption also leads to wastage of hydrogen ions in the kidney tubules. That will also cause alkalosis, right? So investigations, this looks Cushing's, so overnight dexamethasone suppression test and low dose both very high. Usually normal person, what is the level? Can anybody remember? Endocrinology? It should be less than 50 nanomoles per liter. Okay. So both these are screening tests for Cushing's. What are the other screening tests? Anyone can shout?
Spiral wave sample.
Sorry?
Cortisol.
Midnight cortisol and 24-hour urinary free cortisol, right? So now once you establish Cushing's, the next step is to find out what is the etiology. Broadly, what are the etiologies in Cushing's?
Steroid-induced Cushing and any peripheral tumor.
Exogenous Cushing's due to steroids. Endogenous Cushing's. What are the common causes of endogenous Cushing's?
ACTH secreting peripheral tumor.
So it can be ACTH dependent, pituitary, we call that Cushing's disease, ACTH dependent, ectopic, ACTH independent, usually adrenal Cushing's, right? So the next step is to find out whether this is ACTH dependent by doing serum ACTH. So the serum ACTH is very high. This suggests whether patient has pituitary Cushing's or ectopic ACTH Cushing's. Before doing imaging, do you guys know any other biochemical tests that will help us to differentiate between pituitary and ectopic ACTH Cushing's?
High-dose dexamethasone.
High dose dexamethasone suppression test, correct. That will suggest in most of the people with pituitary Cushing's, high dose DEXA will be suppressed, right? In the ectopic ACTH, high dose DEXA is not suppressed. So what you can guys, there are easy ways of remembering this. Now, when there is hyper of a hormone, it becomes autonomous. So that is why the low dose and overnight dexamethasone suppression test in any form of Cushing's is not suppressed. So any form of Cushing's, low dose, overnight, not suppressed. But pituitary Cushing's, still pituitary is the normal, place where ACTH is secreted, right? So in pituitary Cushing's, you can see there is some degree of normality, although it is autonomous, when you use supraphysiological doses of steroids for suppression. So when you do the high dose DEXA, it gets suppressed in pituitary Cushing's, but ectopic ACTH Cushing's is really, really autonomous, completely abnormal, so it's not get suppressed, right? So high dose suppression, you can see day 2, it's not suppressed. You use high dose. In the low dose, 0.5 mg 6 hourly, here 2 mg 6 hourly. Again, very clearly shows that this is ectopic ACTH Cushing's, and also the very rapid onset as well as severe hypokalemia is a feature of ectopic ACTH Cushing's. See the MRI. MRI shows, see the adrenal glands. See these adrenals, you might not be very familiar on adrenal imaging, but bilateral adrenal hyperplasia in this woman. Because of this very high ACTH, they lead to adrenal hyperplasia. So now, ectopic ACTH, where is the commonest culprit, lesion? Anyone?
Lung carcinoma.
Lung. It can be lung carcinoma, it can be lung carcinoids. You can see here there is some bulging in the anterior mediastinum here, and particularly this is quite, obvious on the lateral X-ray here, this area. And you see this CT scan shows a mediastinal tumor, right? If you look at that, that is very lobulated tumor, not really invading. So this looks more like a not a cancer, but look like carcinoid. So this is confirmed diagnosis was the Cushing's disease due to ectopic ACTH from thymic neoplasm. So, but you need to do tissue diagnosis, and also treatment is surgery. But before that, you need to get the metabolic control. Otherwise, the patient can die during surgery. Potassium needs to be normalized. Glucose needs to be controlled. Some degree of control of hypercortisolemia is important. You can use various drugs like metyrapon, ketoconazole, and then the definite treatment is the resection of thymic neoplasm, right? So patient was managed with ACE inhibitors and potassium supplements, spironolactone to normalize potassium, hyperglycemia control with insulin, right? And then ketoconazole use initially mild response, but metyrapon helped to normalize cortisol with marked clinical improvement. Tumor was excised by left thoracotomy. She had a good post-operative listing. You can see patient became completely normal, and since the ACTH stimulus was taken off, patient was hypoadrenal for some time, hydrocortisone for some time. And patient was actually referred to targeted radiotherapy because carcinoid is a pre-malignant sort of condition. So the lessons to learn here is diabetes is a heterogeneous condition. Don't just label all your diabetic patients type 1, type 2, especially they have atypical features, which we call diabetes plus features. So if there's any doubt, refer to an endocrinologist. And then actually I thought of just going through very rapidly some revision notes, also with another very brief PowerPoint on endocrine hypertension. So we know the blood pressure is high blood pressure, hypertension causes a lot of complications to the brain, then heart, then eyes, kidneys. These are the main organs that gets affected. This is the usual sort of summary of how the blood pressure is controlled. Main organs involved are kidney, where the renin-angiotensin-aldosterone system plays a major role. Aldosterone is the key hormone that absorbs sodium from the kidney at the kidney and maintains the ECF volume. And then you have various vasoactive hormones like the adrenaline, noradrenaline, and then the CNS also placed by autonomic nervous system, sympathetic nerves. They have effect on the blood vessels to maintain vascular resistance, and then also kidney. All these plays roles in the maintenance of blood pressure. So this is the renin-angiotensin-aldosterone system, where angiotensinogen is converted to angiotensin 1 by renin, which is secreted from the kidney, from the juxtaglomerular apparatus. It is sensitive to the volume, and so it senses the blood volume and secretes renin. And then the ACE, angiotensin converting enzyme, is responsible for this step here. And the angiotensin 2 has many sort of actions. It's a very powerful vasoconstrictor, and also it has effects on the ADH secretion, and then thereby also maintain volume by absorbing more water. Then also has effects on tubular sodium resorption, and also effects on the sympathetic activity. So angiotensin 2 is something that really contributes by multiple mechanisms to maintain blood pressure. So when to suspect endocrine hypertension? People with young onset hypertension, hypokalemia, then when the blood pressure is resistant. When you call it resistant hypertension, when you cannot control the blood pressure, when you even when you are using 2 or more antihypertensives, including a diuretic. And then if somebody has associated syndromic features, like features of Cushing's, then typical features of pheochromocytoma like headache, episodic palpitations, and so on, then also you need to think of an myopathy, whether we are dealing with endocrine hypertension. So common cause of secondary hypertension, and also detected and treated early, usually can be fatal, particularly like pheochromocytoma, Cushing's, and also primary hyperaldo, usually curable. Interesting, challenging, and these are the causes, common causes: primary hyperaldo, Cushing's, pheo. And then as some of you guys said, the rare causes and the causes of mild hypertension are thyrotoxicosis, and sometimes even hypothyroidism can cause some degree of mild hypertension, and the acromegaly. So these, I think we discussed about this. Primary hyperaldo accounts for significant percentage of hypertension than we thought earlier. It leads to high mortality. and then 37% of hypokalemic hypertension. So it's not always hypokalemia, but about 1/3 can have hypokalemia, and also some of these can have normotensive people also. The commonest cause is adrenocortical adenoma. We call that Conn syndrome. Then it can be unilateral or bilateral hyperplasia. And then there's a condition called glucocorticoid remediable hyperaldosteronism, where the issue is that there's a genetic problem where you guys know that the adrenal cortex has the zona glomerulosa, fasciculata, and reticularis. The glomerulosa secretes aldosterone. Then the fasciculata secretes cortisol. There can be change in the gene where the zona fasciculata secretes aldosterone. So we know that the cortisol is under the influence of pituitary ACTH mechanism. So this can be suppressed by exogenous glucocorticoid, and when that is the normal situation. But in the abnormal situation, in the normal situation, aldosterone cannot be usually controlled by the ACTH mechanism. It is through the renin-angiotensin aldosterone mechanism. But when the aldosterone is secreted not from the zona glomerulosa but zona fasciculata, this condition can happen where people get young hypertension, primary hyperaldo, as well as young stroke, familial stroke, and so on. But for your purposes, mainly you have to concentrate on the first two. The third one is usually not typically questioned at undergraduate level. So when to suspect? Again, these are the conditions: hypertension with hypokalemia, grade 2 or resistant hypertension, young onset hypertension or stroke, or family history of hypertension. Diagnosis: first, any endocrine condition we do screening test. Here the screening test is aldosterone to renin ratio, which is usually high, because when there is autonomous secretion of aldosterone, the aldosterone is high, it leads to suppression of renin. So the ratio becomes very high. And then cutoff depends on the units used to determine. PAC is plasma aldosterone concentration. PRA is plasma renin activity. I think at your level you don't need to worry too much on that, but you need to know the renin aldosterone ratio, right? Aldosterone to renin ratio. And the laboratories have various reference levels. Once you confirm the biochemically the aldosterone to renin ratio is high, you need to confirm. The confirmation is by one of these tests. The rationale of these tests, confirmatory tests, are that in a normal person, when you load them with salt or fluid, then normally your aldosterone gets suppressed, because when you give salt or fluid, you don't need to have too much aldosterone secreted. The other two are not at undergraduate, so just forget about the last two. Just concentrate on the first two. But in primary hyperaldo, even when you give salt and saline, your aldosterone does not get suppressed. So that is how you confirm the diagnosis. So patient needs to be prepared. Usually drugs like ACE inhibitors, aldosterone, receptor blockers that interfere with renin and aldosterone secretion are taken off. But the blood pressure is controlled with things like alpha blockers, non-dihydropyridine calcium channel blockers, or hydralazine. And then the patient is prepared, and also potassium levels needs to be normalized. So the diagnosis, the anatomical diagnosis is by CT scan of the abdomen. But sometimes the tumors can be very small, or bilateral abnormalities can be there, like the bilateral nodularity of the adrenal. So you need to find out whether both sides of the body, the adrenal glands are secretory or non-secretory, because if both sides are secretory, we don't usually want to operate, because if you operate, both adrenals are taken out, the patient becomes lifelong, this, adrenal crisis during stress and so on can be life-threatening. So in that case, we do medical management. So to find out whether the both sides are secretory or non-secretory, we do bilateral adrenal venous sampling if surgery is contemplated. So the management is by usually unilateral laparoscopic adrenalectomy, like here, if the patient is fit for surgery, and then perioperatively, the patient's blood pressure can become normal. But before that, you need to also preoperative also normalize the blood pressure with potassium and antihypertensive service. They can, when surgery is contraindicated or not feasible, medical therapy is by mineralocorticoid receptor antagonism. We use spironolactone commonly in this country, and in other countries there are drugs with lesser side effects, because the spironolactone can cause hypogonadism, gynecomastia. So drugs like eplerenone are much better. Pheochromocytoma, they are the tumors of the adrenal medulla or the autonomous nervous system. Produce catecholamines, typically adrenaline and noradrenaline, but also rarely there are other tumors that secrete other hormones like dopamine and so on. So we know that the catecholamines leads to increase in the heartbeat, blood pressure, can lead to headaches, sweating, the flight, or fight, flight, or fright reaction, right? So if you know why the adrenal, medullary hormones are there, either to fight, run away, or to get afraid, then you can work out the symptoms of pheochromocytoma. They are, can happen in both sexes, and mostly benign, but about 10% can be malignant. Patients can have some degree of hyperglycemia, glycosuria, right? And then about 10% can be bilateral, 10% can be extra adrenal, that is in the sympathetic chain outside the adrenal gland. We call them paragangliomas. So evaluation, we used to do 24 urinary, now this is obsolete, we don't do that. 24 urinary metanephrines is the test that we do in this country. Then in other centers in the world, plasma metanephrines, plasma catecholamines are also done. Imaging typically by CT scan, but you can also do MRI scan, as well as you can also do isotope labeled scanning, like the meta MIBG scanning, when the tumor is not very typical, not seen in the adrenal, as well as if you want to evaluate for metastasis management. Typically, we give alpha blockers followed by beta blockers because of the unopposed action of the alpha receptor. Then once you prepare the patient, you do surgery. So that is briefly on the endocrine hypertension, a brief lecture also. Any questions? So if there aren't any questions, we'll leave at that. Thank you very much.